Hello everyone, I am now presenting a new video on heart specimens, that is CVS, which will include the aorta and the heart museum specimens. Now these museum specimens have been processed after taking the image from the various institutes where I have worked as professor and head of the Department of Pathology, and the original picture may be like this in the museum jar, acrylic or glass jar, and then it is processed to make the image like this. Our references are here, the standard textbooks used by the students. Now this is the specimen first. Look at the specimen, identify and give reasons, and enlist the etiological factors or risk factors for this lesion. Now this organ is abdominal aorta or descending aorta because the endothelial surface, if you see here carefully, there is the opening of the vessels. These openings may be from the intercostal blood vessels if it is the thoracic part of the aorta, and splanchnic blood vessels if it is abdominal component of the aorta. What you are seeing here is the endothelial surface of the aorta is not normal. It is not glistening and smooth. There are seen elevations which are yellow linear streaks, or there are plaques. These are known as fatty streaks and these are known as atheromatous plaques. These at times may be ulcerated. Please note that the openings of the blood vessels or the ostia are narrowed. Now the risk factors for atherosclerosis of the aorta include modifiable factors and the non-modifiable factors. The modifiable factors are hyperlipidemia, hypertension, cigarette smoking, and alcohol. So also chronic diabetic patients. Non-modifiable factors include increasing age, male gender. Now in females up to the menopause, they are protected because of the estrogen, but post-menopausal they are also at the risk. Family history. Then the fourth factor is stress, type 1 personality, and obesity. These are not reversible factors. So atherosclerosis of aorta. Now this is another specimen from the institute. Here we have to mention the complications. Now when the students are asked about the complications, they generally tell the complications like stroke in brain or CNS, or myocardial infarction, or gangrene of the foot. Now these are thrombotic complications, but please enlist the complications of the lesion. In other words, you should mention that the atheromatous plaque may undergo ulceration or plaque rupture. There may be, after rupture, rough surface, thrombogenic surface on the endothelial surface, which will be superimposed by the thrombus, which in turn may be dislodged and may give rise to stroke, CVA, or myocardial infarction or gangrene of the foot. There may be calcification of the plaques, or the plaques erodes the muscular and elastic wall of the aorta. It may lead to aneurysm. So please mention the complication as ulceration, thrombosis, calcification and aneurysm. And you can write these under the heading of thrombosis so that the clinical features are also covered. Now these are some other specimens showing you the similar features. Note the calcification, some hemorrhages and so on. Now these are the specimens which show you the abdominal aorta, and there is this hole or the lesion which is going and showing the outpouching of the wall of the aorta. Now this is about 12 centimeters in length and 6 centimeters in diameter. So this is the lateral surface. I could not remove this glass rod in the jar. So this is the aneurysm or saccular aneurysm of the heart. So describe and define the lesion. Mention the types according to gross appearance and enlist the complications. So this may be a short answer question about the aneurysm of the aorta. These are the atheromatous plaques as seen here. And this is the saccular type of aneurysm. Now based on the shape, there will be different types. So first, let us define the aneurysm. An aneurysm is defined as a congenital or acquired localized abnormal permanent dilation or dilatation of the blood vessels or the heart. Mind you, the aneurysm term is applied to the blood vessel as well as to the heart chambers. Now, based on the shape of the aneurysm, they are called as saccular aneurysm, as in this case, fusiform aneurysm, cylindrical aneurysm, and dissecting aneurysm. Complications of the aneurysm per se include rupture. It may give rise to severe intra-abdominal hemorrhages and patient may go into shock. There may be mural thrombus or thrombus in the sac, and that may lead to embolism. This aneurysm in abdominal position may compress the ureters and present as renal disease of hydronephrosis and so on. Causes of the etiology rather of the aneurysm include atherosclerosis, which is most common, syphilitic, now very rare, and mycotic or bacterial aneurysm. So the bacterial infections may lead to aneurysm of the blood vessels. So this is the case of atherosclerotic aortic aneurysm. This is the rare specimen which shows the aneurysmal dilatation at the root of the aorta, and the intramural surface or endothelial surface shows typical tree bark appearance, meaning thereby there is seen scarring, wrinkling, focal hemorrhages and mural thrombosis. So this is a syphilitic aneurysm of the aorta. You are requested to please subscribe to my channel, and if you go and put on the YouTube Dr. Sanjay Deshmukh Pathology, put Pathology because there are some other videos by Dr. Sanjay Deshmukh or Sanjay Deshmukh. So you will get all the videos of pathology for second M.B.B.S, which will be helpful for your pathology practical and to some extent theory preparation. Please press the bell icon, like the videos, and you are requested to put your comments at the end of the viewing. Let us see the next specimen. The specimen is from 76-year-old male who had history of acute chest pain changing with the position. Now this is a clinical scenario. He also had fever associated with pericardial rub, which disappeared subsequently. So pericardial rub appearing and disappearing. Describe and give your diagnosis and mention the causes. Now this is the specimen of the heart, and here you see that this is the parietal pericardium. This is put off and stretched upwards, and the other one is the visceral pericardium. If you observe the surface of the visceral pericardium, there is rough, shaggy, thin, shredded like surface, right? So that is likened to as if you have taken two slices of the bread, put the butter on it and slowly separated. What will look like is this. So this is also known as bread and butter appearance. So diagnosis of this specimen is acute fibrinous pericarditis on account of its shaggy, rough fibrinous exudate on the visceral pericardium, which resembles the slices of buttered bread and hence bread and butter appearance. And this may be MCQ also. Causes of acute fibrinous pericarditis include acute rheumatic fever, as in this case, acute myocardial infarction, post-myocardial infarction syndrome, which is also known as Dressler syndrome, in which the changes occur 2 to 3 weeks after the attack of myocardial infarction. Uremia is one more cause. So this is the case of acute fibrinous pericarditis. This is another case of fibrinous pericarditis. Now this is the specimen from 78-year-old male with history of long-standing hypertension, who was chronic smoker, and the slice is from the heart transversely cut. What you observe here is this is the marking. So this is the scale 1 centimeter. If we take it that way, then the heart, this is the left ventricle and this is the right ventricle. Now left ventricle, you observe the thickness of the left ventricle in this case was 4.5 centimeters. Now normal thickness of the left ventricle is about 2 centimeters if taken below the atrioventricular junction on the lateral wall of the left ventricle. Now in this case, this 4 to 4.5 centimeters thickness is seen on the lateral wall as well as in the interventricular septum. So this is the concentric thickening or hypertrophy of the left ventricle. So the diagnosis is left ventricular concentric hypertrophy of the heart, and the causes of the conditions are systemic hypertension, most common, aortic stenosis and insufficiency. So there may be valvular disease and secondarily the concentric hypertrophy, mitral insufficiency and coarctation of the aorta. There may be with this specimen, question asked, what are the causes of right ventricular hypertrophy? Actually, right ventricular hypertrophy invariably is result of primary pulmonary disease, what is known as cor pulmonale. Primary pulmonary disease may be in the form of emphysema, bronchiectasis, pneumoconiosis. So there is outflow obstruction from the right ventricle to the lungs. Pulmonary wall conditions like stenosis and insufficiency may also give rise to right ventricular hypertrophy. But remember, this specimen particularly is of concentric left ventricular hypertrophy. Next is a case of 80-year male with history of essential hypertension, long-standing smoking, dyslipidemia, had remote history of myocardial infarction. So there was history of myocardial infarction. So ECG changes may be there in the form of ST segment elevation and inverted T waves. So identify, give reasons and mention the complications. Let us see this specimen. This is the left ventricle. This is the aorta. And what you see here is the normal appearing or within normal limits. The left ventricular wall is seen here, which is maybe about 2 centimeters. But down you see that it is thinned out. And there is scarring seen. So thinning of the ventricular wall at the apex as well as on the interventricular septum size. So this is a interventricular septum, apical region, and there is scarring, discoloration, blackish, indicating old infarct, old healed infarct, and in addition there is this attached blackish thrombus which is known as mural thrombus. So there is an infarct, apicoseptal infarct with mural thrombus. Now the causes of mural thrombus. Of course is the old infarct, and the left ventricle involving apex and septal interventricular wall. Now thrombus can lead to emboli in various organs as we have described before. Now complications of myocardial infarction may be a question asked in Viva, which includes immediate and late complications. Immediately there may be cardiogenic shock, arrhythmias, or at times very severe. It also depends when there is a myocardial infarction, you have to say anatomic position, whether it is apical or interventricular or lateral wall of the left ventricle and so on. In addition, you have to say whether there is complications like this. And in acute phase or severe, the full thickness of the myocardium, if involved, it gives away and there may be rupture of the ventricular, sorry for this spell mistake, ventricular wall leading to hemopericardium or what is known as cardiac tamponade. That means rupture of the ventricular wall of the heart because of severe myocardial infarction, transmural. That means entire wall is involved. Then in long-standing complication, you have ventricular aneurysm, thrombosis, pericarditis, and post-myocardial syndrome or Dressler syndrome. So the specimen is of myocardial infarction with mural thrombus. This is another specimen look at it. The specimen is that of left ventricle, and in the apical part what you see is again fibrosis, thinning of the wall of the apex of the heart. Now you can note that again here it is the original thickness about 2 centimeters, but because of the old thrombus there is an outpouching of the wall of the myocardium at the apical and apicoseptal region. With this thinning and outpouching is known as aneurysm. So this is thinning and outpouching of the apex and part of the interventricular septum is known as apical aneurysm. So that is the healed infarct with outpouching of the wall of the heart, and here you can see there again thrombus which is partly organized because there are lines of Zahn. So mural thrombus adherent to interventricular septum and apical part. Diagnosis: left ventricular aneurysm with mural thrombus in a case of old myocardial infarction. Let us go to the next. Now this is again the serial transfer section from some other museum specimen, and here what you see is there is blackish discoloration in subendocardial region only, involving about inner 1/3 of the endocardial surface. So subendocardial left ventricular infarct. So there may be a full specimen of the heart, or there may be serial sections showing this type of. In various institutions, I have seen various types of specimens, but the main lesions are very similar, and the description is most important thing. And this may be kept at the OSPE. So there you have to write shortly and correctly. This is another specimen from the institute where it is cut, and we are seeing from the posterior aspect. So here this is the left ventricle from the thickness, and this is the right ventricle, and these are the trabecular muscles. Now you see this on the subendocardial surface there is infarct. So blackish brown linear in the interventricular septum region, apical region, and to part lateral wall also is involved. So this is the specimen of subendocardial infarct in the left ventricle. Observe the specimens very carefully. This is the left ventricle. Observe this prominent trabeculae. So identify and describe and mention the consequences or sequelae of the lesion. Now mitral wall, this is the bicuspid wall, mitral wall, shows thickening and see this thickening, curling of the mitral wall, and these are the chordae tendineae. So they are lost here, and there is a fusion and shortening of the chordae tendineae. See this fusion nicely. So these are the classical features of old rheumatic heart disease with mitral stenosis and insufficiency. The consequences of this are dilatation of the left ventricle, and there will be back pressure generated because of the insufficiency and the stenosis, with dilatation of the left ventricle, and there is no in a CPVC, chronic venous congestion of the lung. So outflow is obstructed. Pulmonary hypertension and subsequently a right-sided heart failure will be there. So there will be reverse pressure generated because of this mitral wall lesion. Chronic rheumatic heart disease with mitral valvulitis. Now this is the specimen which we are seeing from the base of the heart. Apex is formed by the left ventricle. So on the base, this is the left auricle and this is the right auricle. And here you see that the mitral wall has thickened and there is a commissure fusion of the commissures. So leaflets of the mitral wall are fused, and subsequently it has led to a opening which is slit like, or it is likened to the fish mouth appearance or buttonhole like appearance, very classical here. So this is the mitral stenosis advanced, leading to the fish mouth type of or buttonhole type of stenosis, mitral stenosis as viewed from the left atrial surface. Now in chronic cases sometimes you get this patch. What is that known as? McCallum's patch. Chronic rheumatic heart disease with mitral stenosis. Yes, this is the specimen of the heart seen from the left ventricle. This is aorta, and this is almost normal appearing or slightly dilated wall of the left ventricle compared to the previous specimens. Now this is a case of endocarditis. What you are seeing on the wall cups of the aortic wall, there are seen polypoidal large vegetations which are rough and irregular surface, which are having irregular and rough surface. You cannot say they are friable because we are not touching them, but definitely they are polypoidal large with irregular surface, rough surface. Both the walls are involved. There is almost destruction of the wall. These are known as vegetations. So there may be questions on the vegetations of the heart also. So there are some types like this: infective endocarditis are polypoidal large, friable, etc. Rheumatic are on the margins of the wall cusp and they are small, firm. Then there may be non-thrombotic vegetations which may be on the either side of the wall cusp. So you have to prepare that short note. Here in this particular specimen, it is the polypoidal vegetations of bacterial or infective endocarditis. Previously they used to say acute or chronic, but with the advent of antibiotics, you don't get classical clinical pictures of both. There may be mixture. So best thing is to call it the infective endocarditis rather than to call it acute or chronic. The complications of infective endocarditis include rupture and perforation of wall leaflets because of the acute bacterial infection. There may be abscess around the wall rings. Here you may see wall ring, abscess or myocardial abscess. This may extend, infection may extend into the myocardial wall or even to the pericardium, leading to suppurative pericarditis. These are the cardiac complications. Extracardiac complications include systemic embolization. So emboli may be there, septic emboli, which may lead to splenic infarcts, kidney abscesses, and in brain myocardial aneurysms. In this condition, there are several MCQs possible, and extracardiac complications of infective endocarditis may be immunologic reactions of the body at different sites. For example, in eye, there are retinal hemorrhages which are known as Roth spots. So, eye Roth spots. In kidney, you may get flea-bitten kidney. Very important. Kidney may show flea-bitten appearance, so the capsular surface shows hemorrhages and petechiae. There may be segmental glomerulonephritis, and on the fingers there may be painful elevated nodes, what are known as Osler's nodes. So all these are important MCQ points in relation to the infective endocarditis. Thank you very much and keep watching my videos.